I was just saying to Dr. Blum here that it's interesting that the first paper I did had it sort of was involved with other papers of reflex work, occipital fibers, and the temporal sphenoidal. And the paper that I'm going to do now is very much conceptually very much similar to the paper that was just presented by Dr. Shelley, conceptually. And all right, Charles, I can go. A sitting disc technique and the relationship to the straight leg raise. And this is basically two reasons for presenting this paper. One is, I think the sitting disc technique is simply a fantastic way of adjusting the lumbar spine for all problems of the lumbar spine. And number two is that the sitting straight leg raise has a direct relationship to what you accomplish with the sitting disc technique. So let's see. Sitting disc technique and the relationship. We did a retrospective case series of 30 patients. Okay, sitting disc technique can be an effective method of adjusting the lumbar spine for any lumbar subluxation or related discogenic syndrome. The straight leg raise is both a subjective and objective test. In this study, we're going to use it as an objective test. I didn't really study the effects of what the patient experienced pain-wise when doing the SLR. And to elicit and locate lumbar and sciatic pain and to judge the functional ability of the lumbar spine, pelvis, and the hamstring. Straight leg raise, sitting disc technique, straight leg raise. That's the way we did it. We did the straight leg raise, we did the sitting disc technique, and we came right back to the straight leg raise. And that's the way we formatted this study. Clinically, the SDT, when done effectively, has been found to immediately improve the SLR findings. Positive SLR, you find a positive SLR, so example would be the straight leg raise could be like 60 degrees bilaterally. You do your sitting disc technique, and then you redo your SLR immediately, and the reassessment will show a considerable improvement in most patients. Considerable improvement in their ability to do the straight leg raise. Here's to qualify for this study. Here's what we did to qualify this. They had to have similar SLR findings in both legs. There's a lot of people that we have that the involved leg obviously is more is not as functional as the uninvolved leg. We tried to create this situation where people had bilaterally similar straight leg raises. There was pain in the lumbosacral area with some pelvic pain in all 30 people that participated in this process. There was vague unilateral low extremity pain, not below the knee, on the opposite side of any spinal curves or leans. And so we did this last year. I did a paper called The Predictability of Category 3 Outcomes. And we tried to take a slice of that study and use it with the SLR. But in the study of last year, if you lean to one side and the sciatic is on the other side and it goes below the knee, the severity of the problem is much greater. Excuse me, let me restate that. If they lean to one side and the pain is on the opposite side and it doesn't go below the knee, the prognosis is much greater than if they're leaning on the same side of pain and the pain goes below the knee. See? So what we did in this study is take only people that had vague leg pain or vague pelvic pain and only leaned or curved to one side or the side opposite the involved pain side, to just try to keep this very specific. Okay? This is a straight leg raise, patient lying in a supine position. The patient then lifts one leg straight up with no knee flexion either side, with no lifting of the pelvis. That's not a picture of me doing it with the straps and the examiner passively helps the patient by lifting the Achilles area until the resistance or pain is met. So it's pretty much a passive lift. It's not real forceful. The degree of lift in our office is measured by a flexometer, which I found to be really effective. Sitting disc technique, developed by Dr. DeJarnett. He didn't actually write about it a lot, but where he put a lot of emphasis in it was in the 1965 Teacher's Manual, which is a tremendous book if you ever can get a hold of it. But he put a lot of emphasis on that in that book. This is the pictures. By the way, we use these pictures in front of where the patient sits. So it's right there for them to follow. Patient sits on a stool or a chair with the back to the side. The doctor makes contact with their thumb just inferior to the tip of the spinous process of lumbar 5. So if you can see this, you're starting on lumbar 5, you're right about like that. You can get pretty close to the tip of the spinous process. The patient is instructed to move in lumbar flexion, pulling their abdomen in while arching the spine back. So it's lordosis to kyphosis. You don't want them doing this. You sort of want them just flexing the lumbar spine. The doctor maintains a holding pressure. This is, I want to emphasize the word holding over pushing. It's a holding pressure. So they're coming into your thumb in a superior direction. At the same time, the patient brings their chin to their chest. That's the only other motion other than going from lumbar lordosis to kyphosis. The patient then moves back to a neutral position while the doctor maintains a holding pressure in the anterior direction. You're not trying to force them into extension. You're just trying to help them come back into a neutral position. At the same time, the inferior tip of the spinous process is contacted. The doctor feels the space between the adjacent spinous process below using the same thumb. This is really the essence of the technique, is that when you're guiding the one above up, you're trying to feel for an opening of the space between the two vertebrae. So there's posterior compression, your thumb is trying to get onto this, and as they come back, their vertebra, their spinous processes, as they go into flexion, they come back, should spread apart like this. You're actually trying to help that process. You're finding the area where it won't open up, and you're actually trying to open it up, or they're coming back sort of like you're guiding it opening, guiding it into flexion. As you do this, you'll notice there's less of a problem for them to go into flexion. It becomes a little easier, and it also becomes less painful for them. Patient moves back to a neutral position where the doctor maintains a holding pressure in the anterior direction. Remember, we're not pushing it, we're holding it. At the same time, the anterior tip of the spinous process is contacted. Feel for space between the adjacent spinous process. That's the key indicator for success of the sitting disc technique. The SDT is indicated when any sign, and in this case I call the SLR the sign, the chief sign or symptom of lumbar involvement is present. Diagnostically, the SDT is needed to be repeated if any lumbar spinous process is painful while executing the SDT, and if the spacing between the adjacent lower spinous processes do not improve. Again, that's your goal, to increase the spacing between the vertebrae as they go into that flexion position or that kyphotic position. Here's the 30-patient study. Of the 30, 3 of them didn't get much change, 5%, 10%, 15%. You can see there was a pretty good 20% change in the straight leg raise in 7 of these people in 30. One person actually got 35 degrees. Joe, I remember his name. Yeah.
Don't say it on the...
Oh yeah, I can't say it. I take it back. Joe wouldn't mind though. But anyway, that's the kind of thing when we got here. There was an improvement, significant improvement. Straight leg raise, note the straight leg raise, do the sitting disc technique, get them right back onto the straight leg raise. In this study, the straight leg raise appeared to be helpful method. And again, we weren't asking them about pain. We weren't really trying to get any kind of subjective information out of straight leg raise. It's all looking at it just on their ability to straight leg raise better than before we did the sitting disc technique. To be helpful method to monitor the functional improvement of the lumbar spine after successful SDT adjustments. The straight leg raise also appeared to parallel symptomatic changes that accompanied lumbar spine improvement following SDT, which includes less sensitivity of the spinous process to palpation, more inner spinous space, and improvement in general lumbar flexion. These are the exercises. We actually incorporated these exercises into the examination. And these are actually the exercises we do. They're all flexion exercises. When it shows improvement with flexion in the SLR, we try to keep them away from extension exercises. And we work with these. And in the examination, I actually do the exercises to show them that the exercises alone can improve the straight leg raise. Straight leg raise, pelvic tilts, knee to chest hamstring stretch, or the all-in-one exercise as I call it, and then redo the straight leg raise, and that alone got my thank you sign right on time. All right, thank you. It's just presented by Dr. Shelley conceptually. And all right, Charles, I can go. A sitting disc technique and the relationship to the straight leg raise. And this is basically two reasons for presenting this paper. One is, I think the sitting disc technique is simply a fantastic way of adjusting the lumbar spine. And to elicit and locate lumbar and sciatic pain and to judge the functional ability of the lumbar spine, pelvis, and the hamstring. Straight leg raise, sitting disc technique, straight leg raise. That's the way we did it. We did the straight leg raise, we did the sitting disc technique, and we came right back to the straight leg raise. And that's the way we can be an effective method of adjusting the lumbar spine for any lumbar subluxation or related discogenic syndrome. The straight leg raise is both a subjective and objective test. In this study, we're going to use it as an objective test. I didn't really study the effects of what the patient experienced pain-wise when doing the SLR for all problems of the lumbar spine. And number two is that the straight leg raise has a direct relationship to what you accomplish with the sitting disc technique. So let's see. Sitting disc technique and the relationship. We did a retrospective case series of 30 patients. Okay, sitting disc technique. I was just saying to Dr. Blum here that it's interesting that the first paper I did was involved with other papers of reflex work, occipital fibers, and the temporal sphenoidal. And the paper that I'm going to do now is very much conceptually very much similar to the paper that